Welcome to Global Medical Office Dialogues. Improving vascular access care is key to improving outcomes for people receiving hemodialysis. In this edition of Global Medical Office Dialogues, our guest is Dr. Walead Latif, an interventional nephrologist and vascular access care expert. A medical director at Azura Vascular Care in the United States, Dr. Latif weighs in on improving patient outcomes by addressing challenges and opportunities in vascular access. Welcome, Walead, to Dialogues.
Thanks, Frank, for having me.
Let's start by talking just a little bit about what you think the impact of COVID-19 has been in the pandemic on vascular access care, both in the U.S. and also abroad.
What we found was that both in the U.S. and globally, that the immediate impact of COVID-19 as it started to unfold as a pandemic was to temporarily increase the incidence of catheter use for new start dialysis patients. And what we found is that relative to historical trends, that the incident use of catheters both in the US and globally had a slight uptick at the height of the pandemic in mid to late 2020. Furthermore, in the US, we also found that there was a shortage of operating room space because hospitals were inundated with taking care of COVID patients. So on a temporary basis, particularly early on in the pandemic, there was a moratorium on use of operating rooms because they were reserved for folks that really needed to be on ventilators and such. One of the things that I thought was a positive that came out of this was that the dialysis access community was able to lobby CMS and other regulators to essentially tell hospital administrators that vascular access surgery was indeed a vital surgery and that it should not be necessarily delayed during the peak of the pandemic. Having said that, there were still some delays in getting vascular access placement in our patients.
What do you think the impact was on endovascular procedures like the ones that you do in Azura? Did you see a decrease, or was that maintained during the time of the pandemic?
There was definitely a decrease in the number of maintenance procedures that were performed on dialysis patients. And the reasons for that were several-fold. One, I think significant number of patients were too scared to actually go anywhere else other than getting their life-saving dialysis treatments. And second, we as an organization sort of made the decision, at least for a short period of time, that in order to reduce exposure to our patients, that we really wanted to only perform those procedures that were absolutely vital. So thrombectomy procedures, catheter exchanges, and patients that we have a long-standing relationship with, that we know that a preventative angioplasty really will prevent a future thrombotic event and therefore not allowing them to achieve continuous dialysis.
Let's shift gears for a second and talk about some of the newer vascular access creation methods that I know you've had some experience and exposure to. Both the ellipsis device and the wavelength device have now come onto the scene and are providing a way to create a percutaneous AV fistula. You want to describe these a little bit and just tell us your thoughts about the role they may play?
I find that the advent of percutaneous fistula has really been a game changer for vascular access care. The two devices are slightly different in the way that they deliver the percutaneous approach. The ellipsis device by Avenue Medical really uses ultrasound guidance only. And with ultrasound guidance, you're able to fuse an artery and a vein together. And this creates an upper arm fistula. And they've now started exploring a forearm fistula using the same sort of technique. The wavelength device by Bard uses fluoroscopy. And what you're doing is you're puncturing both the brachial artery and the brachial vein. And there are magnets that need to be aligned on the fluoroscopy. And once they're properly aligned through fusion, you're able to create the anastomosis, and therefore you get a fistula in that way. Both devices, I think, work well. I do find that this really has been, at least in the last 40 years, perhaps the single biggest game changer in the way we're able to deliver vascular access to our patients.
And have you felt that patients have responded to this? Do you get people asking about it, or do they consider it a surgery, or do they consider it just another procedure? I'm just curious how the patients have responded.
I have found that patients, when they get word of it, are asking quite a bit about this new technique and whether they can qualify for it. I would say that most of them do demonstrate some level of excitement about the prospect of getting a percutaneous fistula, because it's a same-day procedure. It doesn't require general anesthesia. It can be done in a hospital outpatient setting or an ambulatory surgery center setting. And it leaves them with no surgical scars, which I think, from a patient's perspective, is advantageous.
How about maturation times and the need for some assisted maturation in these types of fistulas? Is it any different than the usual AV fistula?
When you review the literature, they don't really track that, and it doesn't really discuss whether there are more maturation interventions that are required. Anecdotally, from folks that have performed these procedures, and from my own personal experience, I do find that they will require a little bit more maturation than perhaps an open surgical technique from a historical perspective. It's a little tough to sort of compare the percutaneous approach to the open surgical approach, because there are significant confounding variables: vein selection, operator technique. So all these sort of weigh in as to whether a patient would require a maturation procedure or not. But generally speaking, I think they do require maybe a slight more in terms of maturation procedures than the traditional techniques.
Yeah, and the other thing that I know we've talked about before is the depth of the vessels sometimes is relatively deep. And are there any issues related to initial cannulation or consistent cannulation of a fistula that's prepared from these deep vessels?
Yes. So that's a great question. I would say that what we don't realize are that dialysis nurses and technicians really use the surgical scar as a visual landmark as to where I should cannulate my patient. With these techniques, there's no surgical scar. So it's not infrequent that until there's a learning curve with a dialysis clinic, they sort of don't know where to begin to cannulate the patient. Now, in terms of depth of vessels, I would say that the ellipsis device by Avenue is less likely to have that issue, because the approach is through more of superficial veins and perforator veins. With the wavelength device, the fusion of the deep ulnar artery with the deep ulnar vein is supposed to help mature more superficial veins. Sometimes that happens, sometimes it doesn't. But when it does happen, it's successful. When it doesn't, then quite frequently you may need a second procedure to help superficialize a deeper vein.
Any other advantages or disadvantages to this method? And then we can talk about some other innovations that are coming down the pike.
Well, I think that the greatest advantage to it is the speed with which you can get patients in to get their fistula. There's no need for cardiac clearance. There's no need to wait for an OR times. It's done under local anesthesia with maybe some conscious sedation. So from that perspective, we really are able to improve on our catheter exposure time, because we can get fistulas created in patients much more quickly. I would say that the minor disadvantages would be, one, the need to educate the dialysis clinic where they can cannulate patients, because again, that visual sort of reminder about where the scar isn't there. And second, I think it's important that when interventionalists are screening their patients to perform a percutaneous fistula, that they're cognizant of the fact that most of these fistulas are more proximal, meaning above the elbow. And if someone has a very readily usable semino fistula that is created by the traditional open technique, that still should be preferred before you proceed more proximally.
We've talked previously about some of the other innovations in the field, one of which is the human acellular vessel that Humacyte is developing. I'm curious your perspectives on the HAV and maybe just describe it and then talk a little bit about what you think its advantages or disadvantages might be.
It's really an exciting time to be in this space, and HAV really is quite the game changer. What it is it's in human acellular vessels. You get a human acellular device or something that would approximate a native fistula. What's exciting about it is that you literally could take something off the shelf, if you will, size it appropriately for the patient, and implant the device. And because it has no immunogenic factors and it's endothelialized by your own native cells, that the infection rates are essentially approximate an AV fistula, which is very different than a traditional PTFE AV graft. So from that perspective, I think the fact that it can be customized and that it can be readily implantable with very little infection possibilities gives it a huge advantage over anything else that's come along in the last 30 years.
Clearly in their early trials, their infection rates and risk was much lower than either PTFE or other methods. I think the other part which was pretty interesting was the fact that percent reactive antibodies and other things in helping people get prepared for transplant were not elevated when exposed to the HAV. So it's an interesting part of the field. What are some of the other techniques and things happening in your endovascular work today that you all are doing? Any other new or novel techniques that you're seeing utilized?
HAV, I think, is still coming, and I think it's going to continue to proliferate. When it comes to other things that I think we're starting to see, there's a new device that still hasn't hit the market yet, which is essentially acts like a blood pressure cuff, and you're able to apply it to a patient either post-intervention or post-dialysis, and you inflate it like a blood pressure cuff to about 20 to 30 millimeters of mercury, and 15, 20 minutes later, you remove the cuff and there's really no more bleeding. And this needs to be more rigorously studied, but what's exciting about it is that I think it will reduce pseudoaneurysms and some of the ulcerations and skin breakdown that occurs from either sutures that we place as interventionalist post-procedure or some of the clamps and other more injurious gauze that dialysis clinics apply.
I know several years ago you began doing some peritoneal-related procedures and placement of PD catheters. Do you find most interventional nephrologists are beginning to adopt a sort of modality agnostic role that they have in providing access to that therapy?
Yes, I've seen a significant uptick over the last 5 years in folks that are more comfortable providing fluoroscopic approaches to placing peritoneal dialysis catheters. And I think that's consistent with the government mandate and the dialysis community's sort of push to get more home therapies. And, PD is certainly at the forefront of that.
One of the things that is clear to me is that our patients have this sort of rampant cardiovascular disease and vasculopathy that's going on. Do you see anything changing in the morphology of the patients that you're taking care of with diabetes and others, that their vessels are either in better shape or worse shape, or what's been sort of over the course of your career some of the changes that you've seen in the types of problems, the types of patients that you're seeing?
I would say that particularly recently, as there's been more patients that have transitioned to home therapy, I find that the cardiovascular morbidity has really improved. Folks, which we know is the case, will tell me that I feel better, I'm taking less blood pressure medicines. I don't find that they're getting hospitalized for volume overload or other cardiovascular related issues. And so I think that is a significant change in the way we were able to take care of patients from a cardiovascular perspective. The second thing that I think has really come to light, which was much more prevalent earlier on, is this concept of high output cardiac failure. in patients with more proximal AV fistulas. I would say that, when I started my career, that wasn't something that was really discussed, but we've had more of an emphasis on looking at that as a potential adverse event for patients. Certainly some of the techniques that have come out to restrict the AV fistula flow, I think has really done a lot to improve the patient's cardiovascular outcomes, kind of reverse some of the left ventricular hypertrophy that we know can happen. And I think that really has done a lot to improve patients' lives.
How about peripheral limb ischemia with regard to Steele syndrome and so forth? Is that still a sort of relevant comorbidity that you see in the patients we treat?
I would say, unfortunately, we still see quite a bit of peripheral arterial disease and limb ischemia and toe and below knee and above knee amputations. I think that our patients need to be studied because they're a unique subset of folks that, as we know, traditionally the CKD patient or the general population patient, some of the trials and some of the outcomes and data that have come from that really don't apply to the dialysis patient. Nonetheless, these patients still suffer from peripheral arterial disease, and rather frequently they are excluded from trials. And I think moving forward, we really could begin to hone in on how do we take care of a dialysis patient's peripheral arterial disease through either pharmacological approaches or endovascular approaches.
Any final comments, Walead, on what you see happening in the vascular access arena these days?
I think if I could just look into a crystal ball for a second, I think we're going to see much more emphasis on wearable devices for patients, both generally and within the dialysis patient population. I think in the not so distant future, we're going to have wearables where we can have monitoring and surveillance that occurs on a 24-hour, 7-day-a-week basis, where a patient can wear something and we can then, through an app, upload it and be able to identify access dysfunction, again, preemptively without having to wait for some of the clinical signs that we've traditionally been trained to look for.
Have you seen any of the wearable devices like the BioIntelliSense device or others like that you've recognized have a component of sensing related to the vascular access, either through sound or through assessment of a thrill or something like that?
There is a device that Renal Research Institute has done quite a bit of research on, and through the use of a camera, the app is trained to sense changes in the thrill and the vibration of the fistula, and based on that, it is able to detect an underlying stenosis. So again, I think this is just the first iteration of what I think will become much more prevalent wearables for folks to detect underlying vascular access dysfunction.
I appreciate the time today, Walead. Thank you very much. Dr. Latif is based in the New Jersey area and is one of our medical directors for Azura, and we greatly appreciate you participating on Dialogues today.
Thanks for having me, Frank. I really appreciate the time to spend with you.